Hello, everybody. I'm really sorry I can't be with you in person. Unfortunately, there was a medical problem that prevents me from traveling at this moment, but I have the chance here to present to you through this virtual means, and have the great pleasure to give you an update on the management of heart failure and some new data, in particular the role of SGLT2 inhibitors in this symposium, which of course is supported by Boehringer. And really, I have the great pleasure of showing you some data that you may or may not have seen before, and some other data that, of course, you know already. SGLT2 inhibitors are really a success story for cardiovascular, for cardiorenal metabolic disease. It all started with successful trial programs in diabetes, and particularly the EMPERIC outcomes trial was positive. It moved on to renal disease and to heart failure. And today we have 6 big heart failure trials, all reporting successful. And really, they have made a big impact on our most recent guidelines. Of course, in reduced ejection fraction heart failure, we had in 2019 and 2020 the reports on the DAPA-HF and the EMPEROR reduced trial. Here you can see the data from EMPEROR reduced with the reduction in the primary endpoint. And what is notable with SGLT2 inhibitors in patients with heart failure and reduced ejection fraction is a very fast benefit we can see already after 1 month. You have a significant difference overall, a 25% reduction in the combined endpoint of cardiovascular death and heart failure hospitalization. And here you can see the meta-analysis published on this, and you see how similar really DAPA and empagliflozin showed results for all of this. A modest overall reduction in cardiovascular death, about 14%, and a very strong reduction in heart failure hospitalization, 26%. And we know, and this is important, that this was very successful across the spectrum of different disease entities, diabetes, kidney function degree, both in men and women, by all age groups. It just works across the spectrum. And focusing for 1 second also on the kidney function, of course, you know that in patients with and without CKD, we have strong benefits, 23 and 28% benefit respectively. And the exciting thing is that really across all kinds of patients, we get benefits. Now, you know, of course, that empagliflozin, when we did our heart failure trials, we included patients up to a GFR of 20. And this compares, for instance, to a GFR of 30 for MRA trials. Below 30, no MRA. For dapagliflozin, all the trials were done up to a GFR of 25. But of course, this is a difference. But of course, knowing that also these drugs work in kidney disease, we really have no concern for the start of these therapies in patients with some degree of kidney dysfunction. There is, of course, a greater concern, and this is new data I wanted to discuss with you briefly, about the dip in GFR we can see. And of course, we know that reductions in GFR are something that that physicians are worried about for their patients. And on the right, you can see what actually predicts the GFR dip that you see with an SGLT2 inhibitor, and you can see that there is basically a bigger dip when you have a higher blood pressure, a bigger dip when you have also a previous kind of situation where you had no heart failure hospitalization. So you might say the somewhat milder patient actually has more of a dip, which is a bit counterintuitive. So let's look into this a little bit more in detail. When you are starting a patient with an SGLT2 inhibitor, you will always see a reduction in GFR in almost all the cases. And here we split the patients. In the tertile 1, you have more than 11% dip. Tertile 2, you have 1 to 11% dip. And basically the third tertile, when you have more or less no dip at all. And what you can basically see is that in the empagliflozin treated groups, you basically have a lower event rate with a higher dip. So GFR dips are associated with better outcomes only in the SGLT2 inhibitor treated patients. This may be a bit counterintuitive, and you say, what is going on in these trials? Well, at the same time, in the placebo-treated patients, you actually see that they had a worse outcome with a bigger dip. So in the patients who have a dip on an SGLT2 inhibitor, the message is that is a normal hemodynamic response. This is what you want to see for your patients. And so do not stop the therapy is one of the most recent important messages. Indeed, the patients who show a dip, they have better outcomes. This is a normal response for your heart failure patient. Then, of course, you want to see how this really works across the spectrum of ejection fraction. And when you consider SGLT2 inhibitors, and we know they work in reduced ejection fraction of heart failure, and of course, you've heard the very most recent updates in the guidelines now with the class 1A recommendation for DAPA and empagliflozin in HFpEF. And the reason are the DELIVER and the EMPEROR PRESERVE trials, where basically patients were included with ejection fractions above 40%, were followed for a little over 2 years, randomizing the patients to 10 milligram empagliflozin or very similarly 10 milligram dapagliflozin in the DELIVER trial versus placebo, and looking basically for the outcomes. One important point I would like to highlight already, because I will show you some data on it, we stratified the patients by HFmREF at baseline, 41 to 49%, or by having a 50% and higher true HFpEF diagnosis. Old story, you might say already, 21% reduction, a very strong benefit seen, highly significant, also significant very fast in these patients. So there is good news. SGLT2 inhibitors work not only for the primary endpoint, which is the combination of CV death and heart failure hospitalization, but also for recurrent heart failure hospitalization and also for protecting the kidney function. Well, again, what about giving this particularly to the patients with CKD? And here you see the results for patients with CKD, without CKD, 20% and 25% benefit for both these subgroups of patients. It doesn't matter how your patient look like, you can give them an SGLT2 inhibitor. Do you protect the kidney? Yes, you protect both in patients with CKD and without. You protect the kidney. So this is all around also for the kidney a good thing. Do you actually prevent the progression to macroalbuminuria in the patients with small amounts to begin with? Yes, you do. You have a significant reduction in the frequency of developing macroalbuminuria. So really, kidney function is prevented. And we have several measures of showing this. Blood pressure. Should the blood pressure be a concern for you when you start giving the patients an SGLT2 inhibitor? Of course, you know that your sickest blood pressure based, your sickest heart failure patients are those with the lowest pressures. And you can see here, for those you get the best relative benefit, 33% reduction when you have a systolic blood pressure below 110. So a very powerful result. You know that many other medicines don't work so well when the blood pressures are lower. And of course, that's not only true for the cardiovascular death and heart failure hospitalization primary endpoint, but really also for the heart failure hospitalization per se. You do get these benefits throughout. I promised you some data on true HFpEF patients. So what about your patients with higher ejection fractions? And first of all, and that's quite interesting, how many of such patients did we have in EMPEROR PRESERVE? We had 5,990 patients in total. 4,000 patients had true HFpEF, and you see them here highlighted, 73 years of age, half of them women, half of them with atrial fibrillation. But look here at the treatment with the yellow boxes. Almost 80% were on a RASI, 84% were on a beta blocker, MRAs 1/3. So these patients are well treated. On top, they receive an SGLT2 inhibitor. And again, they get all these benefits significantly. So for the primary endpoint, for recurrent heart failure hospitalization, for quality of life as well, and for kidney function protection. And here, just for completeness, also the Kaplan-Meier curves for this. On the left, you see the primary outcome, a 17% reduction in patients with 50% and higher ejection fraction. So if you take this together with EMPEROR reduced, you can say, and this is also true for dapagliflozin, of course, you can, across the spectrum of ejection fraction, treat heart failure patients with an SGLT2 inhibitor. Now, if you take all the previous trials in HFpEF, EMPEROR Preserved was the first one to be really successful. This is now validated, and this is important in science. Validation, DELIVER also showed a positive result. And if you look at the meta-analysis of all of this, for the key endpoints between DELIVER and EMPEROR Preserved, no significant difference for all the key endpoints. So this works really throughout. Now, you can look at this also in more detail, and you also have here for cardiovascular death, for instance, a 12% reduction for hospitalization for heart failure, 26% reduction, very similar to the results also seen in reduced ejection fraction heart failure. Now, when you look into the subgroups of patients with preserved ejection fraction heart failure, basically it works throughout. But one interesting subgroup with recent discussions, and tomorrow on Saturday I will have another specific talk on obesity therapy in HFpEF. One interesting subgroup is the patients with obesity in HFpEF. Is an SGLT2 inhibitor actually a good treatment for obese HFpEF patients? Two comments on this. One, in general, for events, the answer is yes. But for weight reduction, the answer, unfortunately, is no. You can see here, and this data comes from the DELIVER trial, very similarly available also in EMPEROR Preserved. If you take the different classes of patients with obesity, the most obese patients have the biggest improvement in quality of life, but look at the right side, they still have only a very small weight change. Even in the most obese patients with 40 and higher body mass index, you only have a 2.5 kilogram weight difference. And if you remember the results with specific weight loss drugs, you of course see that this is a small change in body weight. So yes, for obese patients, we can use SGLT2 inhibitors. I think we should use them, but not to reduce the body weight, but for their general cardiorenal metabolic protection. Now, what else is there to say, and what is really also new? What basically can we say about starting maybe an SGLT2 inhibitor in hospital? Well, we have the EMPULSE trial, and the EMPULSE trial shows us that we can use SGLT2 inhibitors already at the end of a hospitalization period. What was the EMPULSE trial doing? Well, somewhat above 500 patients were randomized, 10 milligram once daily versus placebo, which is, of course, a feature of this therapy. You only give it once daily. There's no titration. There's simply one dose, very few side effects. And then analyzing whether over the next 3 months, you have less death, less hospitalization events, and a better quality of life. And this was done with the so-called win ratio testing. And looking here at the patients, there was a mix of patients with reduced ejection fraction or with preserved ejection fraction. You can see also that 2/3 of the patient had a decompensation status. And then, of course, these patients had NT-BNP values much higher than in our outpatient trials, more than 3,000 at baseline, but still very similar age, about 70 years. And about 33.4% of the patients were women in these trials. About 45% had also diabetes. So pretty much a mixture of the other trials that we have, but started in the hospital. And what do we get? We get benefits. We can show with the EMPULSE trial the first time also in acute heart failure in patients really with worsening heart failure and admitted for it, that there is a combined clinical benefit being made up of reduction in the time to death, reduction in heart failure hospitalization events, and importantly also quality of life is improved. And the win ratio was highly significantly positive. Now, you may be interested in seeing these results in isolation. Here you see the quality of life results, 4.5 points difference. Of course, many patients improve after a hospitalization, but this improvement is even better. This is a higher improvement on average when you are treated with empagliflozin in the EMPULSE trial. reaching significance by itself. And then here, if you look at all-cause mortality and the heart failure hospitalization, also this, of course, the numbers overall relatively small, but very encouraging that you do get this benefit of 35% reduction in event rate. And very few, like in the overall trial programs, very few problems. Ketoacidosis is extremely rare for these patients. You get very few cases of hypoglycemia. Genital infection, you do get 1-2% of cases, and you need to tell patients about hygiene. But overall, this is nowhere near how we saw it in the beginning when we didn't have as much experience with SGLT2 inhibitor treatment initiation. So what happened with the body weight? Well, on empagliflozin, you have about a 3-kilogram weight loss, about 1.5 on placebo, and basically you do have a better diuresis also for these patients. 1.5 kilogram basically is the difference already at 2 weeks, and it stays like this throughout this 3 months study. And the GFR, you might think, well, what about the GFR dip in these patients? Well, already at 3 months, you can show that the GFR is actually higher in the patients that are treated with empagliflozin. So despite a small dip in the beginning, already at 3 months, we have an absolutely better kind of GFR for these patients. So you can use an SGLT2 inhibitor in a broad range of patients of all kinds of ages, diabetes or not, ejection fraction doesn't matter. It doesn't matter whether they have diabetes or not. You can use this and promote basically well-being for the patients, improve their quality of life as well. And interestingly, you can also prevent hyperkalemia, and you can actually improve the initiation of other therapies, particularly then also MRAs for these patients, because you're having this cardiorenal protection. So in heart failure, we have now an unprecedented success story. We have 6 big, important quality trials showing significantly positive results. We have still, besides the MPulse trial, other trials ongoing. There is one with dapagliflozin in acute heart failure patients. It should report next year. And we have also post-MI kind of 2 big studies ongoing. You might say, well, why post-MI? Well, first of all, it's the last area where we simply don't have yet the evidence. We hope with the IMPACT-MI trial reporting at the ACC next year, at the DAPA-AMI trial showing likely at the American Heart Association some benefits. Is there a reason for this? Well, we have the AMI trial, which was about 500 patients randomized, looking really at the change in natriuretic peptides and achieving a significant reduction, also seeing some improvement in ejection fraction, some improvement in E to E prime, so indicating to us that after a myocardial infarct, you get cardio protection. And now let's see whether this translates into less hospitalizations for heart failure, into less mortality over time. And we will see this finally with the full results being reported on IMPACT-MI next year in April at the American College of Cardiology. Now, it leads me to say that we have already for 2 years a 1A recommendation for SGLT2 inhibitors in heart failure patients with a reduced ejection fraction. Across the whole spectrum of these patients, we should give it. Well, in whom not to give it? Well, in type 1 diabetes patients, you may not give it at this moment. There is no evidence for them. If you basically otherwise consider patients that are undergoing now a surgery, well, then wait a few weeks until they have the procedure done. If the patients are undergoing a fasting process, well, wait a few weeks until it's over. What about patients with higher ejection fractions? Well, we now have a class 1A recommendations for HFmrEF and for HFpEF for empagliflozin and dapagliflozin in the ESC guidelines. I'm sure that the other guidelines will follow very soon. It can be used across the spectrum of heart failure. And really, I'm looking forward now to discussing with you some practical other details of doing so. But really, all the data points in the direction of a big success story for SGLT2 inhibitors in heart failure. Let's make sure we are using this. Implementation of guidelines is the key thing. The patients now need to have this treatment. Thank you so much for your attention.